In this chapter, I will review some of the previously covered material and put it together in order to demonstrate evidence of a DVT if it is present in your patient. The point-of-care ultrasonography findings that support the presence of a DVT include a non-compressible venous vessel, the absence of augmentation, the absence of respiratory variation, or even the direct visualization of a thrombus. The more of these findings you have, the higher the likelihood of a true DVT given the proper clinical context. Perhaps the finding with the greatest predictive value is direct visualization of a thrombus. This image is from the same patient used in prior chapters. Can you see the DVT here? Note that the echogenic material seen in the upper left portion of the vessel, highlighted here with the yellow arrow and outline. This demonstrates a well-formed thrombus in the lumen of the vessel. Utilizing some of these skills covered in earlier chapters, you will recall that veins with the DVT will not compress as easily with external pressure from the ultrasound probe. Note that here in this video. Notice that the artery, identified by the strong pulsatile flow, is starting to compress without any change in the caliber of the vein with the DVT. Another skill that may be used is augmentation. As you recall, this involves briskly squeezing the calf of the patient in pulse Doppler imaging mode in order to see if there is an ease of flow proximally. On the left side of the screen is an image demonstrating normal findings when there is no increase in resistance to flow. The image on the right side of the screen demonstrates increased resistance to flow more proximally, as would occur in the presence of a DVT. Another technique you can use in pulse Doppler imaging is phasicity or respiratory variation. Again, this is where you will position the pulsed wave Doppler sample gate in the center of the venous vessel and watch for variations as the patient breathes through their respiratory cycle. On the left side of the screen is an image from a patient's normal appearing vein. Here, you can see that there is good flow with each breath in and out. On the image on the right side of the screen, you will note the absence of any flow during the respiratory cycle, suggesting the presence of a proximal resistance to flow. As you begin to use these skills to look for DVTs in your patients, it is important to be aware of red herrings that may mislead you in your image interpretation. I will now review these anatomic variants or findings, including lymph nodes, Baker's cysts, and pseudoaneurysms. This image represents the finding of a lymph node, highlighted in the superior portion of the screen. You can probably see how this may be easily misinterpreted as a DVT due to its echogenic quality that appears to be within the lumen of a blood vessel. However, one of the ways to help differentiate between a lymph node and a DVT is to simply turn your probe 90 degrees with the structure in question in the center of your probe and ultrasound screen to look at it longitudinally. If it is a lymph node, you will see the echogenic material remain circumferential. Additionally, the anechoic structure surrounding it may initially appear to be the lumen of a vessel in a transverse view, but will remain circumferential to the echogenic material when the probe is rotated longitudinally. When the probe is rotated, the anechoic portion of the lymph node does not convert to a linear, tube-like structure as a blood vessel would when viewed longitudinally. Another misleading finding is the presence of a Baker's cyst. Clinically, this is a challenge to differentiate from a DVT as they both present with posterior calf or knee pain. On ultrasound, a Baker's cyst will have an anechoic appearance that remains spherical when the ultrasound probe is rotated 90 degrees. The challenge of this structure is that it will likely not compress nor have augmentation or respiratory variation, as it is a cystic structure separate from any vascular flow. Similar to Baker's cysts, pseudoaneurysms are another set of findings that you may see on ultrasonography for a patient with posterior calf or knee pain. However, these differ from Baker's cysts in that they will have turbulent arterial flow present when seen in the color flow modality, as seen here. Please note, pseudoaneurysms are also commonly found in the inguinal area after procedures, such as central line placement, cardiac catheterization, angiography studies, and others. To summarize, it is important to put together your ultrasound findings in the right clinical context, as well as recognizing its pearls and pitfalls, such as lymph nodes, Baker's cysts, and pseudoaneurysms. Some tips to improve the accuracy of your image interpretation include using the constellation of skills and image findings reviewed here to increase your ability to differentiate between the presence or absence of a DVT. Remember, you can usually compare your findings to the patient's contralateral leg to see if your findings are consistent between them. In the case of a DVT, it will usually occur in one leg but not the other. Then, in cases of uncertainty, do not hesitate to confirm your findings with a complete study through your facility's vascular or radiology department. In the next section, I will review some tips for image acquisition and saving.